Okay.
the descending thoracic aorta and where it's gone from there. Those are my disclosures. When we look at descending thoracic dissections, this started off in the United States to be able to pick a patient group that otherwise were not good surgical candidates. And when you look at really the natural history of descending thoracic dissections, from the IRAD data, there's a significant group of these patients within the first 10 days that actually rupture and have events. So if we could help eliminate that, and in most cases, best medical management, as we've seen, leads to later dilatation. So the first group that was looked at were patients that had dissections with malperfusion. Everybody agreed in this case that these were not good surgical candidates. Most of the time have very high paraplegia rates and complications, and obviously you can't treat them with medical therapy, so this was a good place to look at the endografts. The dissection, I think, as everybody is familiar with, this is from a patient in the ascending aorta, where you can see where the entry point, then this why the outside layer, which is very weak, dilates. This is an ultrasound image, and we'll see some in a little while of how we characterize these, the true lumen, the false lumen, and also you can, with the grayscale, quantitate the flow after you've covered an entry tear. This is a patient who had an acute dissection with malperfusion. You can see here on the 3D how it comes down. And then below the renals, there's actually no flow, so he doesn't have pulses. It had some abdominal findings. What we're able to do is to position the endograft here, just at the subclavian artery. You can see how the IVUS shows us true from false lumen. And as we come down along the aorta, it collapses up against here the celiac, the SMA, and in the renals, and that's why below there's really no pulses with complete collapse. Once we put the endograft here at the subclavian, and then further down, here's the subclavian again covered, you can see that the true lumen opens up here at the celiac, the SMA, and the renals, and so perfusion to the distal vessels where we normally have to operate and open that up is available, and then if there are abdominal findings, to be able to treat that later. And it really came out to be very impressive that in these group of patients, this is that patient 5 days later, you can see the true lumen is nearly all the way open. There's reperfusion down through the rest of the abdomen. And there was a series of 50 of these cases done in the United States in these investigational IDEs that was then used by the FDA to make other comparisons to commercial devices. And with this, there's now been, Dr. Bavaria just presented at the Society for Thoracic Surgery, 50 of these patients that were in the original Medtronic trial that have 5-year follow-up now, so that there's data out. And in this group, these again were complicated type Bs. 86% of them had malperfusion and 20% had rupture, with 14% of these patients having cerebral spinal cord symptoms. So this is obviously a very ill patient group. And when you look at now again out to 5 years, as you look at on the top here, all-cause mortality, about 70% are alive at 5 years. On the bottom panel there, freedom from any dissection-related mortality is better than 80% at 5 years. And freedom from secondary interventions, again, there are some, but still about 85% at 5 years remain intact. So this is a good indication that not only this is a good acute treatment, but that the durability over time is also quite good. If you look at here the changes in the true and false lumen, and I can summarize it for you easily. The true lumen goes up, the false lumen tends to collapse down, and where there were 86% malperfusion, and again these ruptures, the false lumen at thrombose, where the endograft is placed, in nearly about 90%. Now a persistent problem is dilatation of the infrarenal aorta if over time that continues to enlarge. And that's being addressed in others, but this initial management with the endograft, particularly in the malperfusion patients, has been documented as a superior treatment. Now, the other places to look at it that are more controversial are, as we mentioned, enlargement in the infrarenal aorta, or some of the other indications, persistent pain, uncontrolled hypertension, or at the end we'll talk about the asymptomatic patients. But what we're really trying to prevent now at this stage, this is a patient who had a dissection treated down here to the visceral vessels, but over time you can see this is mostly thrombosed, but the infrarenal, and this persistent dilatation then is a complication that we have to look at and be able to address. Over time, we've looked at what the dynamics are, and when you see, as we mentioned, if the dissection stops at the renal arteries, the volume of the true lumen goes up, the false lumen goes down, and over time, the entire volume tends to go away. But in another group of patients where we looked at chronic dissections, the results were similar. The true lumen volume went up, the false lumen went down. But in the infrarenal aorta, again, when this dissects all the way down into even the iliacs and the hypogastric vessels, there's continued enlargement in a significant group of these patients. Now, the INSTEAD trial, which we all thought originally was acute dissections, turns out to address this chronic group. And this has been published, as you've seen, many of you are familiar, at 2 years in a group of patients that had endografts compared to best medical management. There was no difference in the outcome, but at 5 years there was a crossover from the group that were treated in the medical group. About 40% of those patients actually crossed over and ended up having an intervention. So this is again problematic and something that we need to be able to address over time. There's also been other studies that have looked at this. This is one that came out of a collaborative group of about 2,000 patients in the United States. And when they looked at it, really even in the chronic patients now, there's an indication because of the high risk with the surgical interventions that the endovascular treatment is a reasonable option. This has even gotten more interest lately because the mobility of the flap is an important part of who regresses and who doesn't, and there's a potential now new classification system where people have looked at less than 7, 7 to 14, 14, 30, and then 30 to 90 days out with this trying to decide when is the best time to intervene, not only to prevent early complications, but also to get that to remodel and be able to have that occur. This is a 30-day follow-up from the SVS that had a group looking at this indication, and when you look at it, there's a lower freedom from adverse events early on. And in this particular publication, it looked like treating the patients at 7 days or less had a higher regression rate, and in the underlying part there, can't quite see it with the pointer, but further out there was less regression. But again, this is something that, and maybe Alan will show you some of the images that he's got related to MR and classification of how that dissection flap mobility is going to impact on the treatment. So that in summary, for patients that have malperfusion, the endograft has really become, much like it has with the transections, the standard method of therapy, and then for these other continuing chronic patients and how we're going to be able to limit that mobility of the flap still continues to be addressed. With that, I'll stop. That's my 2 talks. I think Dr. Kracher was next.